Okay, hi everyone. I'm gonna keep letting people in as people keep joining, but I'm gonna get started. I want to first thank Dr. Campbell for coming on tonight and talking with us, and I'm gonna give the floor over to her to let her introduce herself. And then if you want to tell us a little bit why you chose orthopedic pediatrics in the orthopedic field. Also I'm recording this and it will be posted later.
Cool. Hi, I'm Nancy Campbell. I went to college. I'm from Long Island originally. I went to college at Penn State, and then I went to med school at CCOM in Chicago, Midwestern, and then I did my residency at PCOM in Philly, which is where I rotated at St. Christopher's as a PGY 2 and 4. And I did my Peds Ortho Fellowship at the University of Utah in Salt Lake City. I finished that in 2023, July of 2023. And then I started at St. Chris last year in September, and I've been there now a little over a year. So why Peds Ortho, right? That was yeah. So I've always really liked kids. When I was in med school, I actually thought for a minute maybe I would do like gen peds surgery, but I hated general surgery. And then I did my peds rotation and just fell in love with being in a pediatric hospital was awesome. I like the wide variety of pathology that we treat. You know, peds is one of those specialty, well, it's the only specialty really, where you can do like hand surgery, and you can do limb surgery, and you can do spine deformity, and you can do big hip surgeries, which I really like being able to operate all over the body. I also really like getting to know patients and their families. And in peds, you can get to know people from like age, I mean, for DDH, like a baby, and then you follow them until they're 18, which I really, really enjoy that like longitudinal follow-up care. Yeah, that's great. Kids also just get better so much more reliably than adults. You know, I don't do any workman's comp. I don't give out pain meds. I don't have people really coming in and saying they're in pain. It's like real problems. They want to get better, and it's just much, much more enjoyable.
Following off of that, so like what specific what specific things do you do as a pediatric orthopedic?
So I kind of right now am doing a little bit of everything. I think my practice right now is mostly trauma, just because that's kind of what my clinics are full of. That said, I really enjoy doing spine, like scoliosis and spinal deformity. I like DDH a lot. I do see a fair amount of like baby DDH, but I don't do a lot of DDH surgery just yet. I like neuromuscular disorders a lot as well, like cerebral palsy. I like doing those big hip cases for those kiddos. I do a lot of hand trauma. The only thing I really don't do is a lot of sports stuff. So like knee scopes, shoulder scopes. I don't do any scopes. And then I don't do the deformity stuff because one of my partners does that too. So like limb deformity and angular correction, things like that.
And then you kind of already answered this, but was there anything that specifically inspired you to go into orthopedics in the first place?
Yeah. So I always liked surgery because I like having a tangible problem that we can, you know, I can fix and go home knowing that I actually solved the issue at hand. Um, and then I liked ortho because I like patients that are injured rather than sick, you know. There's a big difference there. I was an athlete, you know, it's kind of like the typical ortho thing. So I got injured, and that's kind of how I found out about the specialty. And I just think it's fun to get people back to moving because it's something I really value. And so the ability to let people do that again is awesome. Kids is great because you are giving them like their whole life back, it feels like.
Also, if anyone has any questions, you're more than welcome just to put them in the chat or raise your hand, but I can keep going with the questions that we have. I just wanted to let everyone know that. Regarding what do you think? Sorry, I'm looking at the questions.
Oh, that's okay.
What specific skills do you think that are essential to be successful in the pediatric orthopedics?
Aside from like technical skill, which is important, you know, in all aspects, I think one of the oh, there's my cat. I think one of the bigger skills is the ability to communicate, because your patient is not the only person in the room that's going to have questions. Honestly, half the time my patients don't even have questions because they're like little, or they have some sort of disease that makes them, communication with them is difficult. But being able to talk to families and parents and teach them what's going on and break things down for them is really, really important. Being patient is really important. Everything in peds takes longer, whether it's like you have to have patience because kids cry and you want them to see their physical exam and you want to see them walk, or getting kids into the operating room takes longer. I think those are the biggest things, like being able to communicate and then having patience. If those aren't your forte, I don't know if peds would be like the place for you.
Did you automatically know that you wanted to go pediatrics, or did you ever think like there was other specialties or other subspecialties you were interested in?
I liked hand a lot. I did a lot of hand in my intern year, so I really enjoyed it. I liked the people in hand are kind of like the people in peds. They're like a little more laid back and a little more relaxed, which I really liked. But at the end of the day, I just felt like um, operating in just one small area of the body would not really fulfill me. I also like hand pus is something that most hand surgeons have to deal with, and it wouldn't be the fit for me.
And then kind of going into a little bit of work-life balance, what does a typical day look like for you? And then how do you balance the demands in your field?
So I'm very fortunate. My job is very comfortable. If I'm in the OR, I start at 7:30, which really means we're not even in the room until 8 because everything is slow. And then I'm home. If I have 3 cases, sometimes I'm home at like 2 o'clock, 3 o'clock, 4 o'clock, something like that on an OR day is typical. And then clinic day, I start at 8:30, so I'm showing up at like about 8:30, and then I'm home. Usually I'm out of the hospital by 4 o'clock. So it's really nice. I take call with six partners, so we all split it up. So it's one every 6 weekend. It's one of the major holidays a year. It's very, very manageable. Work-life balance for me right now is like the best it's ever been. And I keep waiting for like the other shoe to drop in it to get worse, and it's just not going to. Um, so that part is really manageable. Obviously, very different from training, and I think very different even from other jobs, because where I trained into my fellowship in Utah, they're peds ortho surgeons, but they were working much longer hours and they were way busier. And I think they really liked it. It just kind of, you find what suits your personality.
And then how do you feel like balancing like family with going through residency and like just your career in general? Like how has that been for you?
It's hard. In residency, it's very difficult. I think making sure that everybody who's going to be immediately around you, like whoever you live with or whoever's nearby, has to understand the demands of what training is. It typically, like I work with a lot of residents now from a lot of different programs. They're all pretty predictable in the sense that like intern year, second year, third year can be pretty tough. And then usually when you're a senior, it does get better. So there is a light at the end of the tunnel. But just kind of setting the expectation that like residency is hard. You're going to miss important things. You try to go to whatever you can, having people that can support you and not pressure you when you need time to just like sleep, I think is really, really important. Could like bonus credit if you get along with the people in your residency program, because then you have a lot of like-minded people who understand what it is that you're doing all day and your struggles, and they won't really ask those things of you because they know that you don't have much to give after the work week is said and done.
Do you have any advice on managing the healthy work-life balance that you've noticed in your career that's worked for you?
Yeah, these questions, by the way, were so good. My husband and I were talking about how insightful they are. So good, whoever came up with these, they're really great. I think for me, I would say, so I asked him, he's an ortho trauma surgeon, and his answer was find really good buddies to drink with and find time to drink with them every once in a while. And I'm so dorky in comparison. I was like, find a couple healthy habits that you can stick with. Like to make myself feel human, I need to like have, I need to go to the grocery store. I need to have like cooked dinners and bring lunches. So I would meal prep on Sundays, even if that sucked. And it was like a couple hours where I could have been doing something else. That made me feel human. And then finding time to exercise for me was really important. So like, even if it's just 20 minutes, 3 times a week on a really busy trauma rotation, which totally happened, but it still felt like, okay, these are like 20 minutes that I'm carving out just for myself to put it all aside or work out frustration or get some energies. I think finding a couple things that make you feel like you, even when you're like really tired and burnout, and holding on to them and not letting them go throughout even the craziest rotations is probably the best advice I would give.
I think that's really good advice. I definitely think we always have to find something that we enjoy, even now in school. And it's good to hear that there's light at the end of the tunnel too.
Yes, no, don't totally. I was telling someone the other day that like med school is so hard. Um, every year is hard in a different way. Auditioning is really, really hard. And then residency is really, really hard. Fellowship is hard because it's just a year. And then I think I'm happier now with my job than than I could have ever imagined. So it's totally worth it, but it's just a long, tough road to get there.
And then regarding the orthopedic field, how like being a female, how has that been for you and what was your experience being in a male dominated field and being a female in this field?
Yeah, this is a good question too. It's, you know, it's better than the stories I've heard from the past, right? Because there's definitely a lot of program. The majority probably have at least one woman or have had a woman, even if they don't have one now. Um, when I was in interviewing, there definitely were some programs that were like, I was told they're not girl friendly. So just like you can try, but you have to want to be the first, trailblazing. And that wasn't really for me. My program had, like I had a female classmate, there were 6 of us. And then every year pretty much has like at least one girl. And so it felt diverse in that way. There's always, not always, sometimes there can be like challenges, right? Where like people might make comments like, oh, are you strong enough to do whatever? Of course you are. You just figure out ways to leverage what you have. You don't need to be like 6'5" and 250 and bench, a ton. You just figure out ways to leverage your own strength. One thing that was that I remember in residency, we would rotate like every 3 to 4 months, like different hospitals. And if I followed one of my boy classmates, like there was nobody knew the code to like the women's locker room, but it's easy enough to just ask and get that information. So I think it's definitely becoming more friendly. I think there's definitely room to grow. Um, I also think it depends on where you go in ortho, for like fellowship and beyond, right? Like my practice, my partners rather, I have 2 women. So I sometimes like forget that ortho is like males, majority, like 90% male. And I would be lying if I said that didn't factor into part of the reason I chose peds, because I wanted to be surrounded by like, people who thought like me and looked like me and stuff like that.
Was there ever a time throughout your career, throughout your training, where you felt like either from the other students around you or preceptors or patients that you felt like there was like they compared you to their male counterpart? Um, if you know what I'm asking.
Yeah. I think like, do you get treated differently sometimes by like patients or preceptors? It's interesting. I think in training, I don't really think I did that much. Maybe I'm trying to think if there were any instances, because there had been girls that had come through. It didn't really happen all that much to me. I really don't think so. Patients for sure. Like I would walk in and say, I'm Dr. Campbell. And the assumption is always that I'm the nurse. And you kind of get used to that. Even now, like just a couple months ago, I was like I was consenting a patient in pre-op. Like I'm going over the surgery with them. And the dad was just like, so when's the doctor coming in? I'm like, cool. So it totally happens. I've gotten better now. I think it's So now I introduce myself as like, hi, I'm your surgeon, Dr. Campbell. So this way they know it like gives them a role. That's harder in training because you just say I'm a resident, and I think people don't know what that means. So there definitely is a difference there for sure. We have a long ways to go before, the assumption is not that women are the nurse in the room.
It looks like we have a question in the chat, and it is, do you have any particular research interest that you are currently pursuing?
I'm not a huge research fan. I'm gonna be honest. Most of the research that I did to get into med school and then get into, I don't think I even had much research to get into residency, to be honest. And then to get into fellowship, you usually need a little bit. It was all like, I have to do this to get the next step. I'm writing a textbook chapter with my chairman right now, but it doesn't feel like, it's not like clinical research. It's kind of just like reviewing what's out there and putting it together kind of thing. I commend anybody who likes research. It's really important to keep the field moving. I just find it really mind numbing to do.
Did you have a lot of research going into like during your residency? Did you have a bunch, or when you were in med school at the time, did you do a bunch at all?
I didn't. To get into to get into residency, I didn't really do much at all, to be totally honest. I did the honors college at Penn State when I was in undergrad, and so I had to write an honors thesis. So I talked about that a little bit. I like can't remember anything I did in med school. In residency, I did like the bare bones. Um, PCOM's not a really big research institution. They're trying to improve that part of it and get us more involved, but we don't have like a research block. I know some programs have like dedicated, 3, 4 months, 6 months to like churn out papers, and that's great, but we just didn't have that. And so to do papers on top of working a lot was just really challenging. So I did a couple of like reviews. Nothing was like original research, nothing in any of the big articles, and I still made it. So it's not like, I know that it's important, but it's not like the number one thing.
And then there's another question in the chat. It said, since you mentioned that your husband is an orthopedic trauma surgeon, do you have any advice for medical student couples who are both interested in surgical specialties and how to navigate those complexities? My fiance and I are both interested in ortho.
Yeah, that's hard. We actually met later, so we didn't go through any of like the training together, which I'm thankful for. Whew, I guess I would say to try to hopefully like the same programs, and even so you can make your rank lists. Like couples matching, I'm going to be honest, I don't know any couples who have couples matched into ortho the same year. If you're the same year, I would just try and rank, your top 5 or 10 in the same geographical area, so at least you could try to see each other. I know couples who did long distance for residency and they made it work, so it's definitely possible. It's hard, but you don't have a lot of time to do anything in residency, so it's not like, it wouldn't be the end of the world. Not ideal, but
And then you mentioned that you guys met after like the match process, I think is what you said. So
Mhm.
how was that for you, and how like did you manage your time with a significant other as well as being both busy in residency?
Yeah, I think it really helps that we do the same job because it means that like we totally understand when someone gets home late or like is just like beat and doesn't want to talk at the end of the day. You just come home and you're like, I'm just like spent, I need a minute. And then it's like for us, it's like pretty additive also. We talk a lot about ortho and like we go over cases together, and that part is like really, really fun. It can be challenging when we're like on call different weekends, because then it feels like, okay, this weekend we only actually have 2 weekends to do fun things. And that's a little bit part of life. But all that said, like all of those, like we met when I was going into fellowship. So that's why it's kind of hard, because residency is like such a time suck. And then once you're out of that, you usually get so much of your time back. So it's really just like making it through that part of it and knowing it feels like forever, but it's not. It does end at some point.
And then another question from the chat. Do you ever have peds patients who have difficult parents, and in what ways in what ways are they difficult? And then a follow-up question on that one was, how do you accommodate the parents' wishes while still doing the best, doing what you think is best for your patient?
Yeah, we definitely have difficult parents for sure. That's why a lot of people, if they don't go into peds, the number one thing is people say the parents. Um, I don't mind it. I look at it as a challenge. I'm like, how can I get through to this person to tell them like is what I think they need? Um, it's kind of interesting since most of my practice right now is trauma. It's usually pretty easy to sell them on something because their kid has a broken bone and it's like this, I can show them the x-ray and say like, we need to fix this. And then they're usually pretty agreeable. And if they're not, you always remember like, you don't always know best. Like I don't always know best. Like that's this parent, this is their kid. And maybe, this is what's really valuable to them. And, you can fix a lot of things later on if like, they get a malunion or whatever. You can sort it out later if they choose not to go the surgical route. What was the second part of that question?
How do you accommodate the parents' wishes while still doing the best, while still doing what you think is the best for your patient?
I think that kind of loops back into like the communication aspect. I think if you're a good communicator and you take the time, even though it feels like, especially clinic, there's like a busy day, but you're like, I got to sit down and explain this. So they really understand why we need to do the surgery and what the benefit's going to be. Most people are reasonable. And if you present them all the information, especially if there's like a clear surgical indication, if you go over this will happen if we don't do it, this will happen if we do. I have gone onto Google in patient rooms and pulled up pictures of different things to show them, especially with like deformity stuff or like neuromuscular hip dysplasia where the hips are out and there's different things we need to do to put them in. I try to show them so they can see, and then people will understand. It just takes a lot of time to get there. um, but I think it's just like a lot of coaching. If they still won't agree to it, I will just do really short follow-up, right? I'll just be like, instead of seeing you in 4 months, let's see you in 4 weeks. And then like sometimes take another x-ray and be like, see, this is why we should fix it because it's not getting better. And then, they almost always agree to what they think is best. And if they're not in agreement, usually it's just because they're nervous or afraid. And if you can kind of calm them down and they trust you, then usually you can get where you need to go.
And then another question, any recommendations on how to balance becoming a competitive applicant if you do not love research? It seems like it's becoming more crucial to make yourself competitive.
Yeah, it's really tough. I would try to suck it up and get something done. It's interesting when I went through step one was like a score. And so that was really helpful to give you like an automatic way to kind of stand out, and now it's just like pass fail, which I think is better because it's trying to make people not a number, but it also makes it more difficult to stand out, especially if you're like test taking is my skill. Um, I would try to push yourself to do at least one project, especially if it's in ortho, that's like bonus points, especially if it's with someone who could potentially write you a letter of recommendation saying why you'd be great in ortho. Because then it's like, wow, this guy. Oh, you worked on research with him. And then it also opens up the field to a lot of things to talk about in your interviews. If that's not available, then I would say, like, if there's a residency program near you or that your school's affiliated with, if you can get hooked up there and try to get to know the residents and ask them if there's anything you can get involved in, that's also a huge way to get a leg up because then they will know your face and they'll know you're a hard worker. And then when it comes time to like auditions and interviews and stuff, I think that could be really helpful. It's really just about like getting people to like recognize your face and have a good impression associated.
And then, would you be able to talk about some of your audition rotation experiences and what that was like for you?
Yeah. I mean, auditioning sucks. It's so hard. It can be so expensive to like live in two places and whatever. Um, I think I had a leg up in some ways because I'm a female, and so there's just not as many girls. I have like I have tattoos also, which is really helpful if you're somewhere that's open-minded because I automatically stuck out. I think what what I look for now, because we have auditioners at St. Chris and I'm involved in PCOM and I go to interview day and whatnot, or interview days, I should say. A good auditioner is one that is like their presence is known and they're in the room, but they're not annoying, which is a really fine line because you want people to notice you, but you don't want to do too much. You never want to be too comfortable, right? It feels like, you know, you do a 4-week rotation, you feel like you're part of the team, but always remember you're not, and be on your very best behavior. Like avoid making like the jokes that could go the wrong way, you know, even if you feel like, oh, I really know these guys, because you don't. When you're in the OR, some good advice I got was like, recognize, like open your eyes and see what you can do to move the case along, like, which isn't a lot. So there's not much, like bring the bed in and out, which sounds stupid, huge help. Find a roller board. If we need to use a roller board, ask the nurse, like, are we gonna need a roller board to move the patient? Do we need a bump? Because you can go find blankets somewhere. Do you need a tourniquet? Because you can find different sizes. If they're going to wear SCDs during the case, you can like put them on the legs and plug them in. These all sound like little things, but if a resident notices that you've done them, they're like, oh, they're paying attention and I don't have to ask them. Anybody can do what they're asked, but if you can do something without having to be asked, it's a huge help. Putting the candy cane on the bed, you know, that sort of thing, taking the bed out of the operating room. And then at the end, asking, can I bring the bed in? And asking anesthesia, can I bring the bed in? Huge help. It's funny, we actually notice when that isn't what happens. And then I would say notice how the program interacts with each other, because, you know, 5 years is like a long time. It's half a decade. It's when a lot of people who are not in medicine, and those some who are like moving on with their lives, or like buying homes and having kids and doing all these fun things, and you're like in the hospital the whole time. And so you want to make sure you're surrounded by people that you like, that get along, that have a similar sense of humor, that you feel like, okay, I'm working 80 hours this week and it sucks, but at least I'm with like my best friends. And I think that makes a huge difference in job satisfaction and burnout level. Pay attention to how much autonomy residents get in the operating room. I think that's really important. I would say most programs that I went to, everyone graduates like a competent surgeon. And so what was most important for me was like, will I fit in here? Will I feel like I belong, especially as a girl? Like, is this a place that's going to be accepting of me and my quirks, or am I going to feel like an outsider? Because that would be really, really hard to do.
Going off of that, was there anything that you've noticed from students that are auditioning now that you've always, that's like an automatic like no or bad thing they've done that you're like, yeah, you should not do that, or stuff that you should avoid?
Not nothing egregious has happened really. I think the thing I notice is just when people feel a little too comfortable. It's hard because you know, you're coming to work every day and you want to, everybody wants to belong and feel part of the team, and I get that, but I think it's like making silly jokes because you feel like, oh, I know these residents, I'm already one of them, kind of it's like a little off-putting. I would just remember that you're not yet there, and it's still a job interview. It's like a month-long job interview at the end of the day. And I think the people who forget that are the ones that we notice are like, maybe not the right fit.
I've got another question. What is your advice on someone who wants to start a family but feels like is looked down upon during residency?
Um, well, I mean, is that a woman asking or a man?
Yes. It's a
A
woman.
woman. Yeah. So I think you can totally do it. It but it's really tricky because I think when you're like auditioning and whatnot, I don't know if I would want to ask that question. Like, has anybody had kids? It should be allowed. We should be allowed to ask that for sure. But I don't know how that would be received, if I'm being honest. PCOM, I know like nobody had babies for a long time. And then my classmate actually had 2 in residency. And then the class behind us, one of their chiefs had a baby. And then obviously all the guys have kids. And so I think you totally can do it. It is hard because I mean, you get like the 12 weeks of leave. I think you probably have to use your vacation time in that. And that does I mean, the question is always like, does it set you back in training? You can make up for it for sure. So if you want a family, there's definitely a way to have a family in residency. It's becoming more and more common for sure. And so it it shouldn't be looked down on. I think the reason why it does get looked down on is just because depending on the call pool, like other people have to like help pitch in and pick up the slack, you know? But in my program, at least, we were all like happy to, because like I loved my co-resident and I was just so happy she was having a baby. You know, I thought it was like really cool that nobody had done it and she was going to be the first one to do it. So I would say residency is really important, but your life will extend far beyond residency. And so if that's important to you and the timing is right, which it's always like right in that window, you do it and everyone will work around it.
And then another question from the chat. If we are interested in peds ortho, is it necessary to go to a residency with a peds fellowship?
No, not at all. Peds ortho is ortho fellowships in general. The competitiveness of them kind of changes every year depending on who's going for what. It's not at all like applying for residency. Residency is always going to be competitive. Fellowships, they change. Like trauma is really competitive. Hand, I think depends. Joints is usually competitive. Peds typically is not, because most people, it's like ortho bro is not the guy that's going into peds. So there's a smaller amount of us that want to do it. So you definitely don't need to go somewhere that has a fellowship. Usually, if you have good letters of recommendation and you've done some, maybe like even a small amount of research, typically you get interviews wherever you apply to. And then usually you like, if you know people who can make phone calls for you'll probably get one of your top couple choices. Just because there's not a big pool of people who want to do it.
And then kind of following off that, could you talk about how you chose your fellowship program and just a little bit more about that?
Yeah. So I you know, it's only a year, so it feels like there's all this pressure on it. Peds specifically, they're all all the fellowships are designed a little differently. Some of them are rotations, because peds, you can do sports, you can do hand, you can do deformity, you can do spine. What else is there? There's trauma, there's foot and ankle. So some of them do like 2 months on each of those, right? With like set schedule and rotation. I didn't want that because I knew I didn't want to do some of those things. I didn't want to waste any of my precious 12 months on them. So I wanted a place where I could like choose your own adventure. Utah. So when I was interviewing for fellowship, it was 2020. Everything was virtual, which was great because I saved a shitload of money. I didn't have to travel. But everywhere's numbers were really, really low because it's elective surgery and nobody was having operations done. Utah, their numbers actually went up because all the kids just like went outside and played. So there was still a lot of trauma. And so I kind of figured like one of the reasons I went there was we didn't know how long the pandemic was going to last, but at least I'll still operate and get a good experience. They do a lot of spine there, which I wanted to do spine. I really like scoliosis. They also do a lot of hip stuff, which I like. One of my partners now, Megan Gresh, she went there for her fellowship. And so I was able to call her and just be like, hey, what was it like? What was your experience? And so she kind of filled me in. And then she ended up like making a phone call for me to help me out. And then the last thing with peds, and I think a lot of other specialties do this too, is like call some of them, because you're done with your residency, you've passed your written board. So a lot of them will have you take attending level call. I personally didn't want to do that because I figured I'm going to spend the rest of my life struggling by myself in an operating room. I want to learn from someone during that 12 months. And so that kind of automatically weeded me through the programs, because not everyone had like buddy call with an attending. Utah was also like a really cool place to live for a year. It's really beautiful.
And then you kind of started talking about it, but what other things should you look for during, like when you're looking at fellowship programs?
Yeah, so definitely I would look at like what kind of stuff they're doing. Like every subspecialty in ortho has this, right? Like sports, it's like the question is, do they do hip scopes or do they not do hip scopes? Hand, it's like, do they do replants or not? Foot and ankle, I don't know. Foot and ankle probably has its own thing too. Like joints has like, do they do joints trauma or do they just do joints? That like getting into the weeds to know that information, I think is really helpful. And then knowing how much like independent operative time, I think is important. Some programs are like very academic, even in fellowship, and you spend a lot of time just like watching. I definitely didn't want that at all. Volume number, like when you're interviewing for fellowship, places should be very transparent about how many cases you should expect to get. And so that's helpful. Sometimes knowing like where the people go later on, I think is helpful in some way to see like, do they all, like in Utah, like a lot of them ended up actually staying in the Utah area, which was kind of interesting. I think those are probably the biggest, along with the other stuff I mentioned. Like, is it a scheduled thing? Do you get to pick what you're doing, or someone telling you? Are you taking call? Is it backup call, or are you attending level call? Those are like the biggest things I think to consider.
And then another question from the chat. It says a follow-up question for auditions. As DO applicants, do you think it's worth a try to audition at traditionally allopathic ortho programs, specifically if they've never taken a DO before?
This is audition, right? Not just apply.
Yes, says audition rotation, but I'm probably talking applying too, both sides.
Yeah. I think applying totally, it's expensive, so you'll lose money, but I don't think you lose anything, else. I think it's like you have to know thyself. If you are going to be a good, like a great auditioner, I think, sure. I don't think it would hurt. The only way it would hurt is if there was an osteopathic program that you could go to during the same time. Maybe it would hurt your chances just because you would be losing out on a place where you have a real fair shot. I don't think that a lot of programs, maybe they will be, maybe I'm wrong, would be like super forthcoming about the fact that like we're never going to take a DO. I don't know if anybody will tell you that, and I just would hate to have you lose a chance where you could have gone somewhere that would have really taken you seriously as a candidate. You just have an extra couple of weeks, so I don't think it hurts at all to get more experience. Are you guys mostly third or fourth years?
I'm actually a second year. I'm not,
Okay.
Lane's a fourth year. I'm not sure about others. I think there's a few third years. There's a
Okay.
first year, a third year
Okay.
BCom,
Okay, cool.
few second years.
Yeah. I would say for the younger, anyone who's basically not a fourth year, who's like still setting up their auditions, one thing that is not a bad thing to consider. You can kind of be strategic with how you make your rotations if the timing works out. In the beginning of your audition season, maybe put programs you're not as interested in. You'd still be happy to go to, but they're not like your top choice, because you'll get experience and you'll learn things. You'll get to do fracture conferences. You'll get to pick residents' brains. You'll get to see stuff. And then as you get closer to the place you actually want to be at, you'll have a lot more experience. You'll be like, all right, this is how I can be helpful, stuff like that. Oh, another thing, auditioning, that it's really helpful if you're in the hospitals, like not in clinics and stuff. Like if you can learn the size, web roll and plaster or fiberglass, whatever they use, ace bandages, like for splinting and things, if you can figure out where that is and how much to get, if you're ever on call with someone, like that is tremendously helpful to a very busy resident who could just like document while you run and go get supplies. And that will be remembered for sure.
And then what advice do you have for all of us like pursuing ortho or even peds ortho? Like do you have any advice for us as we're going on this journey?
Yeah, buckle up. No, it's the best job. Like ortho's the best job. My husband and I say this to each other all the time. Like it's the most fun. A good day in the OR or clinic is just like, I would do nothing else with my life. And trying to remember that like the pain of residency is not, and med school is like not forever. It gets better. It's all worth it. Try to learn something every single day, even when you're like so tired and scrubbing cases that feel like they're totally irrelevant to the practice that you're going to have. Like, especially if you're like post-match resident, like when I was like scrubbing joints and I was like, I'm never going to do this procedure again. What can I learn from it so I don't waste this whole day? Always try to leave with something new, even if it's just like how to hold an instrument or how to do something, anything, I think is really helpful. Um, recognize when you're like burnout and you need a little break, and it's okay to not like crush every single day. You're never going to do 100% everywhere. If you're crushing at work, you're probably not going to be crushing at home. And if you're like crushing at home on the weekend, having a blast, you're probably not studying for cases. It's okay for all of that to coexist, and like be gentle with yourself, and you'll get through it. And the last thing I would say is, like, I talk to med students about this when they rotate at St. Chris, because someone talked to me about it when I was a fourth year med student, about like having a backup plan. Ortho's competitive and it's hard. And if you're all in, like, be all in for sure. If you're all in, but you're terrified of what happens if I don't match, like, you sit down and think with yourself, like, if I don't match on match day, how will I feel? How will I react? What's my backup plan? Is it going to be that I scramble into like something else? Is it going to be that I'm doing a research year? Is it going to be that I like have a meeting and figure? I just think having some sort of idea of what to do if what you want doesn't happen is a safe plan, because like you've invested so much in your education at this point. I think it's smart to invest in what if, you know, um, even if that's just like, I don't know, I'm going to scramble into whatever's out there, like that's totally fine. But then you have to like, have that conversation with yourself a little bit, and never tell anybody if you're applying for anything else. I don't think there should be as much shame in it if you want to do like, you know, back up something, so, like a whole nother specialty. But don't ever tell anybody in ortho, because that'll be automatic.
And then there's another question in the chat. Can you talk more about mentorship and how to connect with your mentors?
Yeah, I think that's a great question. I think it's really important to, like, if you can find someone early, I think it's really helpful. Um, and I think it's okay. I think it's a good idea to have mentors at different levels too. Like if you're a first year med student, maybe find like a third year med student. If you're a third year, maybe find a fourth year who just did what you're doing, so you can like pick their brain. And then once you match, it's easy. If you're auditioning at school, or you can find a resident to latch onto, but that can be a little trickier because you don't want to be too needy, whatever. Once you match and you're in a program, finding like a senior that you like and you connect with, I think is really helpful. I think a lot of programs are built on that. Like I know PCOM especially is like, it's a lot of residents teaching residents. And so that kind of fosters that relationship. Attending wise, I think most people, I mean, I'm especially in peds, like we love to teach. And so connecting people and trying to build that relationship, maintain that relationship, help out with any questions you have along the way is something we all really like to do. So if you work with someone and you like them and you get along really well, don't be afraid to ask like, hey, could I have your email? So if I have questions along the way, like no one's going to say no to that. We all were you at some point. And it's kind of fun on both sides, because it's fun to like hear your perspective and be like, wow, I'm so old, but I was there once. It's like, it's fun for everybody. So don't be afraid to put yourself out there and keep those relationships open, keep the connections. Like I got my job at St. Chris because wouldn't leave them alone about hiring me, because I had been there before. And so like that literally can give you a career if you just like, foster that relationship.
What's the best way to keep those connections like with mentors? Is in like maybe like it's a physician and we're only like a second year. So what's the best way to keep that connection so you're not like going 2 years or a year without talking to them?
Yeah, I think like reaching out every, like, I don't know, 6 months or something, like 4 to 6 months, because it's not a huge ask. I think I did this program, I don't know what it was. It was like some mentoring program for ortho specifically. This is not helpful because I can't remember what it was called, but anyways, I was in residency, I think, when I joined, or fellowship when I joined, and the student that I was working with was in third or fourth year, and we had scheduled phone calls like every 4 to 6 months. It wasn't too much. It was basically just like a touch point to be like, hey, how's school going? And then, she would tell me like, it really sucks. And I'd be like, yeah, it totally does. Like it's, how's it going with ortho? Are you still thinking ortho? And we would talk about programs and stuff, just like reaching out. No one will think it's overbearing if once a quarter you send an email that's like, hey, I'm just wondering if we could touch base, you know? I think that would be helpful. If they don't get back to you, then maybe that's not the right person because they're maybe not meant to be a mentor, and keep looking. Don't be afraid if someone isn't the right fit.
And then another question in the chat is, a couple of us in this room are currently students at Nordicom in Provo, Utah. We would love to chat more about you with your fellowship experience at the U and living and working in the Utah Valley area. Is there a chance you could share your contact information with us?
Yeah, for sure. Do you want my email? Um,
I think whatever's easiest for your best for you.
yeah. So my email, my like personal email that's easier for me to answer because on my phone is N as in Nancy, M as in Marie, C as in Campbell. So NMC5104 @gmail.com.
Okay, it's NM Campbell 5104 @gmail.
Yeah, NMC.
NMC,
Yeah.
and then CAMBELL.
Oh, sorry. It's just
Oh,
like the letters, like N, like my
oh,
initial
okay.
NMC. Yeah.
Sorry.
No, that's
Okay.
okay.
I'm gonna send it in the group chat. Okay.
Oh yeah, perfect. Yep. Jermaine's got it.
Okay, and then I think another question was about finding a job after fellowship. How was that? And then like transitioning from fellowship into your official like job career.
Yeah, that's a really good question. It's like interesting to hear you even think about that now. Because I definitely didn't think about that until I was like a fifth year resident. It's hard. It's harder. I'm not gonna lie, it's a little harder than you think it should be, considering how long it takes. Like, I don't know. I thought like, okay, I did college, I did med school, I did residency, I did fellowship. Like the perfect job is just gonna like land in my lap. And it did. I'm really, really fortunate, but it didn't land in my lap. I like badgered them to create a position for me, and that my timing just happened to work out. Um, I think most people probably start looking for jobs around PGY 5 year. You match for fellowship as a PGY 4. And so then you know that you're going to do a fellowship, you know where you're doing a fellowship. Usually, you know where you want to live, not always, but sometimes you do. And so you can start looking in that area. Um, Depending on the area and the availability, kind of depends on what offers are there. And then it's a little bit of like thinking about what matters most. There's like the job itself, there's money, and then there's location. And it's not often that you will get all three of those things. And so figuring out which of those is most important, which is middle, and which is like who cares about it for you is really important. Um, and it's I signed my contract in January of fellowship year. So like 8 months before I started, which I think is pretty standard. One of my co-residents signed his contract in like June of fellowship year. So he was almost done. So he started a couple months after me. We're both working now. Everything's fine. I think it's more stressful the later into your fellowship year it goes when you haven't signed. My co-fellow at Utah had already signed by the time she came into fellowship. So there's like lots of different ways to do it. It just depends on what you're looking for and what you're willing to compromise on, um, and things like that. And then there's like when the time comes and you're looking at jobs and you get a contract, you have to, I would say, make sure you have like friends, um, or people that will help you read it, because it's like a language that we don't really learn, and learn how to negotiate, which is also something that you don't know how to do, because like up until that point you've just been so desperate to get in everywhere that you don't really realize that you have power now. So that part is definitely an adjustment. And then even once you start practice, it's an adjustment of like, I'm in my first contract, I'll negotiate for my most first contracts are 3 years typically. And so I'm in like the second year of my contract, and I'll negotiate, next year. And I'm definitely going to negotiate for stuff different a little bit, because you like learn as you start working what works for you and what doesn't work, what you want, things like that.
And then someone just asked, have you heard of any ortho surgeons exploring locums?
Um, yes, I have. Usually it's people who are like, off cycle. Like we have a fifth year that just rotated with us that's like applying for fellowship. His timeline is a little different than the typical person. So he's going to finish residency, I think, in like September or October. And so he won't start fellowship for until August. So he's got some time. I know someone else who did that also. And so they both did like locums positions. Um, I think they were both happy. Usually locums like pays pretty well and it's not a bad idea. You know, you're operating and you're like learning on your own, which I think is really helpful. So if that's kind of what you have to do, I don't think it's like um, a bad idea. It's a job, right?
And then I think I'll open it up if anyone has any other questions. I'll like sit here for the chat, but one more final question from me would be, what trends do you see shaping the future of peds ortho?
That's a good question. Uh, in peds ortho specifically, um, I think I'm like just trying to think of like you mean like operating or like workplace or like
Kind of both, like either one.
yeah, I think like one thing we're continuously moving towards in all of orthopedics is just figuring out how much we could do outpatient. And I think that kind of keeps evolving, like elbow, like supracondylar fractures in peds used to be like everyone gets admitted and all these, and now it's like you can do a lot of them as an outpatient. I think stuff like that will continue to evolve. I think the technology that we have for a lot of the deformity stuff is evolving in really cool ways, like especially spine, which I really like spine surgery. So we have a lot of cool new stuff on the way. We're still several years from figuring out exactly the perfect indications for some of those procedures, like tethering and stuff. But I do think when we figure them out, it'll be really neat. I think ortho as a whole is moving towards like just like medicine in general. There's more of an emphasis on like wellness and DEI and like trying to make it so that people don't get burnt out as much and being open and supportive. And I think that's like only going to be beneficial. I think the more people talk about burnout and or just like how hard work is, stuff like that is, it's just better for everybody because it's hard for everyone. Everyone experiences it. And so the more people are open about it, the more people are talking about it, I think the better off we all are. Yeah. Oh, one last thing I would say, anyone who wants to do like any sort of subspecialty once you're in residency. So it's a little down the line. Like going to conferences and stuff is super helpful too. Like peds, we have like IPOS and POSNA. And so when you're a resident, if you can go to those things, you can like meet people from different fellowship programs. And that's a nice way to like get your face out there before you even apply.
And then if anyone has any other questions, if you want to put them in the chat now or just unmute yourself and ask them, I'll give you guys a few minutes to see if anyone has any other questions. It does not look like it, but I just want to thank you again for coming on here and chatting with us. It was very much appreciated for you to take time out of your night for be able to come talk to us.
Yeah, absolutely. Anybody who has questions or like concerns, shoot me an email. I will get back. Not always super prompt, but like usually within a week or so. So yeah. Good luck.
Thank you so much.
Yeah, you're welcome.
Thank you, Dr. Campbell.
Yeah, you're welcome. Have a good night, guys.